I want to welcome you to the Department of Public Health Pediatric Workshop, and co-hosted by the University of Kentucky Department of Pediatrics. My name is Gwen. I am your hostess for the day, along with Miss Yvonne, who you've already met. Whatever. Our first speaker today is Dr. Carmel Wallace. And you'll see on his bio that he is a professor and chairman of the UK Department of Pediatrics since 2012, which means he's a very distinguished gentleman. And when I asked him to do this, I was getting recommendations on who to get to do the well child, and he was like, oh, ask Dr. Wallace, ask Dr. Wallace. And it's like, and when I asked him, he's like, Gwen, I've been in administration so long, I'm not even sure what a child looks like. But I know he does have some clinical experience. What was interesting, and we didn't put it on here, is the man has a BS in engineering from UK before he went to UK medical school, which I thought was a very unusual route. But if you think about engineering and but I just thought that was really cool. So, Dr. Wallace, I will let it up to you. And I'm going to go check on the parking lot.
Good morning. I have so much power and time there while I'm giving this lecture instead of not introduce people. I'm new to this. Then when she picked the subject I was going to talk about, physical examination. You don't realize how hard it is to do something, to talk about something.
Can't hear you. Sorry.
You hear me now? So much for that electrical engineering. So say, you know how hard it is to talk about something for 40 years, that you've been doing for 40 years, and you don't have a patient in front of you to demonstrate. I spent most of my time figuring out how I was going to do this talk, not what I'm not doing it. For the ones of you who don't know the rest of my story, I was in private practice in rural Kentucky for 30 years before I got conned into coming up here to the university. I was supposed to be slowing down, and that didn't work out well. Can we dim the lights? When some of these slides will be easier to see. I don't know how many of you do direct exams. I mean, probably the most important part of these exams I try to teach my residents and students is observation. When you walk, we'll turn the dim lights.
That's what I was looking for. Nope, that's in here.
There's nothing that dials.
You're going to let me take the notes, right?
Yeah, take the phone. Anyway, the exam really starts at the beginning when you walk in the room. Is that too loud? It seems like I'm in
No.
That's too.
Okay.
I'm having a hard time hearing you from back here.
Welcome to allergies industry. They follow me in Central Kentucky. But the observation, the most important thing is maternal infant bonding. You see some moms who are just covering, see other moms who have them out on the lap or they're still sitting in their infant seat and there's no eye contact with the mother. So that's an important, that may be important. There may be a mother who's exhausted, but it may be more important than that. See what the interaction is with the older child in college, and it's appropriate. I used to tell my moms who were hollering at their kids and trying to discipline them in the exam room, if you do it at home, they do a better job in the exam room. I got some bad looks, but you all are smiling, so you understand what I'm saying. You cannot teach a child good manners in 15 minutes in an exam room. It's an ongoing experience. Fortunately, I have a deep voice and I'm a big guy, so they usually shut up when I tell them to, so that's pretty good. Also notice, is the kid a happy kid? You know, most kids are bright-eyed and bushy-tailed. It's not until the adults get into their life that they change. But is the child very anxious? I've got a standing rule, if I can't get a kid to make eye contact with me and talk, let's say from 3 to 4 years up, and it's hovering over the corner, they have anxiety disorder to talk with otherwise. No matter what the child psych people say. And the other part, most of them will, how many of you deal with sick children? I teach my residents that within 30 seconds of walking into an exam room, you ought to be able to determine whether the child's sick or not sick. By not sick, I mean going home with some treatment, real sick, going into the hospital. That takes a little bit of experience, but with observation of the child, it's to be a pretty natural thing to do. The newborn, get the child out of mom's arms. I'll examine the child in mother's lap. If I'm doing a newborn in the first month of life, I've got to get them out of mom's lap. Get them on the table, get them unwrapped. We used to have a rule in our office, I wouldn't let my nurses take a temperature for 5 minutes after they unwrapped the kid during the winter months. It was amazing how many fevers went away. But, watch for spontaneous movement. I mean, kids are going in all directions continuously. Back in the 70s, they had an Olympic athlete, I think it was in gymnastics, try to mimic the movements of a 6-month-old. He was exhausted after an hour. After an hour and a half, he dropped out of the experiment. So these kids are constant motion. So look for symmetry of movement. And it doesn't have to be purposeful, but it's just there, it's always moving. Start the exam as far away from the head as you can. Now that's not practical for a 6-year-old, I understand. But for a 6-month-old, if you start at the head, you just blow the next 10 minutes of the exam. If you start at the toes, you still stand a chance. If mom's hovering, which most younger moms will and some experienced moms still do, it just explains to her everything you're doing. She'll finally sort of decompress and maybe step away. Occasionally I have to ask them to step away. I'll just step in her way and get to the baby instead of me having to examine the baby with mother over there. They catch on after a while. Some easier than others. Now, starting with the exam, we're going to go back to the opposite way I just told you to do it. Quite frankly, that's the way I thought about it as I was doing it. The head of the child, the infant, is the gateway to the brain. The anterior fontanelle. All of you can probably tell stories about mothers being overly protective about the soft spots. My favorite one is when we used to come into the office with cradle cap and it'd only be over the soft spot because they were afraid to touch it and scrub on it. But the frontal lobe, or skull lobe, parietal, occipital, temporal, sagittal sinus, suture, chromis sutures, and then the metotic suture. That's the big one in front. And it comes in all kinds of varieties. You will notice when you examine a child sometimes they got a big V, they look like a Vulcan, Star Wars. Most of the time that's not a problem, but I tend to watch those kids a little closer as far as head circumference. And I've only seen a couple of kids over all my career that have an unusually large metotic suture. Two most common scalp lesions that I see is one, the caput, and two, the cephalohematoma. If you see kids in the first week or 2 of life, the caput is probably still there. It's the large swelling area in the occiput parietal region. from where the child used their head as a battering ram to come down the birth canal. I explained to mothers that's why birth was so easy. It will go away. However, if after a week it's not going away and there's a localized little mushy knot, that's a septal hematoma. That's actually a collection of blood between the bone and the periosteum. It's a tough tissue that covers the bone. It doesn't cross sutures. Now, sometimes it can indicate a skull fracture, not very often. If you get real panicky about it, a skull x-ray would be appropriate. A CT scan is not appropriate. So don't send them to the ER. Septal hematoma lies outside the tough tissue lining the skull bone and the skin. It's usually just fluid, some release. If it turns blue, it was also partly hematoma. Septal hematoma is between the periosteum and the bone. And notice it does not cross the suture. The biggest questions I get asked is skull shapes. My baby's got a funny shaped head. That's after the swelling goes down, usually about the second month. And there's three common varieties. Plagiocephaly is a narrowing of the head with a little asymmetry. Brachiocephaly is a flat occiput. My mother used to say that was a sign of a good baby, and I used to try to explain to her that the baby's lying in one position like that all the time. It's not necessarily good. I lost that argument. Brachiocephaly with plagiocephaly is probably the most common. That is interesting because it's frequently associated with some torticollis, and we've all had mothers come in to say, my baby always has her head turned one way or the other way. And you look and there's a little flattening on one side of the skull, maybe a little asymmetry. If you make sure there's no sternal clavicle fracture, there's no knot on the sternocleidoid mastoid muscle, you can almost always say that's probably positional. And there's a couple of easy ways you can fix that without going through expensive physical therapy. And it's just change the position the child is put in the room. Think of it as mothers, you probably put your kid in bed with the head always the same direction. When they're in the kitchen sitting in their infant seat or carrier, they usually went the same place. So the kids started showing a favorite. And you would see that flattening on one side of the head. Just for the simple fact of putting them head at the other end of the bed, changing the position of their infancy, making them enjoy the rest of the world. Usually takes care of that. That doesn't do it overnight, but it'll take care of it. Some interesting stories about that. But, kids, if the choice is look at the back of the couch or the wall of the crib, they're probably going to look around and see where the noise is, especially if they have a big brother or big sister. Sound like a water buffalo coming through the room. The eyes. Probably get as many questions about eyes as anything else. I refuse to get into a discussion with grandmas about what color the eyes are. I just get to agree with them and say, it could change, but I don't disagree with them if they say, let's say they're pink, I probably agree with them. The eyelids, you're looking for symmetry. You're looking for conjugate movement of the eyes. Now, infants up until a certain age don't follow very well. They may not follow past the midline for a longer period of time. I've given up trying to estimate when that is. I just watch the child's eyes, and as long as they're trying to move together, I don't get too excited though. I remember that when I had my first one, my son home. I guess at the end of the first week he was home, I was sitting there in the lounging chair with him propped up, facing me, and all of a sudden he developed rotary nystagmus on one eye and external rotation of the other. I will tell you, it took Dad about a minute to compose himself before he could tell his wife that to go away. Because she had to be over my shoulder when he was doing that. And it did go away. Pupils are equal in size. There are a few variations in normal in which the pupils will be different. But as long as I don't care if they're small, I don't care if they're big, as long as they're about the same size, you're doing good. On older child, you can check for reactions to light, direct, and central. It's difficult. I just like to shine a light there and see if they constrict and if it's symmetrical. Fundoscopic exam, if you can get a red reflex on an infant, you're doing good. if you're trying to do a fundoscopic exam on a kid that's preschool, good luck. I tried every trick in the book, and I'm probably 50% accurate. And I would hate to put my accuracy up against an ophthalmologist who would claim to be better than that, but I still think they're playing it by ear too. The droopy eye is one you can ask a lot of questions, especially as a child gets sleepy. They're getting droopy eye. I suspect several of them in the room do. I know one of us does. If I get sleepy, one eye's going down. But the problem with it is it can lead to astigmatism. It can be due to astigmatism. It can be due to muscle imbalance. And it can really lead to amblyopia, where you literally start to block out the vision of one eye, and the brain plays a game and says, just not going to pay attention to that, so that part of the brain doesn't continue to develop well. And you get functional blindness. I wish we could get this line. I gave this to a little red. It's called a scleral hemorrhage, subconjunctival hemorrhage. Probably the source of more phone calls than I would like to admit. When a child's 3 to 5 days old, when they could have been home for a day or so, start getting some comfort level, and all of a sudden they open up their eyes to the mom sees this little crescent of bright red. She just knows she's done something really bad. Once again, it's trauma induced from birth canal. It goes away. I used to love to see them when they were in the nursery and pick it out, because I could tell mom about it and not have to get a phone call at 10 o'clock at night. But relatively common. Pupils, if they're irregular, these are cornea, you may have a problem. That's why I usually, once I know the static, make sure it's true, I usually let a pediatric ophthalmologist evaluate those. Like I said, we don't get into discussions about colors of eyes and pupils. Reactions. On a younger child, you're not going to be able to do a direct and central exam. Just look to see if they're reacting. If it's a bright room, just turn the lights down if you can. If your exam room's like a lot of exam rooms, there's no windows, all of a sudden the room gets dark, use an ophthalmoscope as your light to see where you're going so you don't bump into something. Probably the red reflex is the most important eye exam you can do on an infant, young child. We've also taken photos where both eyes are bright red, and we see, darn, the little red line under the camera didn't work to take care of that. But it's a reflection off the back of the eye, and it's normal. If you don't see both eyes being red when you examine, the best way to do that is just step away with the ophthalmoscope about 2 feet to 3 feet apart. If you see a red reflex on one eye and black on the other eye, that's an urgent referral. That's probably a cataract at the start. No line will do it. You see, like on the bottom one here, where you see a line like that. The problem with that, the retinoblastoma, is very high. And we're not talking like you get an ophthalmology appointment the next week or 2 weeks. You're on the phone to the ophthalmologist saying, "I want one now," and give the receptionist a hard time if she doesn't give you one. Strangest eyes. I thought this was a Stephen King novel when I saw it, but I couldn't resist putting it on there. Cross-eyed or wall-eyed, obviously self-explanatory. Strabismus is the general term. Strabismus doesn't tell you which one it is. The one you have to watch for is the cross-eyed when you have one eye turning in. Young infants have eyelids that will sometimes give you a pseudo-strabismus look there. And the best way to check on that is, once again, go about 2 feet away from the child with your ophthalmoscope and look to see where the little red, the white dot is on the eye. You don't have to look through the ophthalmoscope to get the red reflex. Just see where it reflects. The light should be, the corner light should be symmetrical on both pupils. if you sit in the middle of one pupil and the lateral part of one pupil. In other words, this one doesn't show it. I could not find a picture of it. This side you should see the like a lot of reflection right in the middle. This side you see it over here, not applied. That means the kid really hasn't got his turning in. So, once again, that's not an urgent, same day, next day. I found a ophthalmology appointment that's pretty close to it. By the way, you notice I'm not talking about physical examination. I decided to just talk about anomalies. Figure you guys have done enough clinical exams. These are just variations on the film. The hardness, the low, helix, cone of light. Out of all the middle ear exams you do, if you can visualize the cone of light and it looks a little longer than it is wide, you probably have a normal eardrum. If it looks like this little short, squatty triangle where you don't see it at all, then there could be a problem with fluid. If it's a round ball looking at you there, that's fluid with pressure pushing outward. Now, both of those would require ENT. If you have malformed lobes of the ear where you don't have one, that's an immediate referral to pediatric ENT. That child has a hearing problem on that ear until proven otherwise. I've seen a couple of kids with malformed pedia who did not have hearing problems, but most did. And it's not an uncommon issue. In fact, I had a little boy when he finally left for practice at 12 and moved out of town, I was glad to see him go. He had, I think it was his right eye, or ear was involved with microsis. And he wore his hair long. So here I'm doing the exam. Every time I start on the good ear, I flip over and look at the other ear, and he starts laughing because he knows I'm going to find one with his hair out of the way. So he was still giving me a hard time when I left town after I did the 6th grade checkout. For some reason, I never learned about putting a note in the front of the chart on that one. Can you all see this skin tight? There are two types of ear ties that you'll see. One like this, which has a broad base. So you leave those and let them see ENT later in life. Who, if it hasn't started to fade away a little bit, we're going to want to do surgery. The reason why you don't try to tie that off is sometimes it's cartilage underneath there, and it don't heal well if you do that. So it's a little skin tie just hanging by a flimsy stalk, tie it off, clip it. Probably been done in the nursery, so you all won't see unless you're doing nursery rounds. So I'm quite sure you guys are used to seeing perfect oral hygiene. I didn't see any of those. Of course, this was, we still had, we call it Eastern Kentucky milk mouth. We had the light carrier with the front feet. That improved by the time I left for once again, what you're looking at is symmetry. There's very little going on in the mouth that's good. Doesn't show up with some type of asymmetry. So looking at normals and figuring out, and each time you do an exam, mentally clicking off normal tonsils, normal medial, normal gums, pays off in the end, because then when you start getting real busy, you automatically do it and you don't start skipping things. This is something that most of you have seen, but I bet you most of you don't know what it is. You notice the asymmetry of the lips on the grimace. If you notice the eyes are symmetrical, the muscles on this part of the face are symmetrical. This is hypoplasia of the vicularis muscle. And people who have sort of funny grins, shapes of the mouth frequently have that. It has nothing to do with Bell's palsy, all that stuff. So I've seen many of those kids come in at 2 months of age with somebody with diagnosed Bell's palsy on it. Tongue tie. How many of you have seen tongue tied kids in your practice? How many of you thought it was abnormal? If you want to get an argument started, a speech therapist, pediatric dentist, and a lactation consultant in the same room. You know, in the years I've practiced, and I was a practicing physician until I became 95% overhead, I could probably count the number of kids on one hand that I thought had a significant tongue tie. And I do agree with speech therapists that they get the tongue in the back of the teeth line, the gum line. It's not going to cause a speech problem. That speech impediment is probably learned by somebody else in the family speaking like that a lot of times. But this has another reason. 2 reasons to get the tongue clipped. Hygiene. Think about how many times a day you use your tongue to go off or run your gums to clean something out. And lactation, latching on. They haven't totally sold me on that one yet. But I'm willing to go along with them if they will make a good argument. I do not consider a procedure that's done in the office. There are occasionally some blood vessels there that keep bleeding when you clip them. And it's better done by a dentist or a pediatric dentist. Sometimes the dentist will do them in the office, clip, then they've got to stop the bleeding, not bleeding. Can you see the little white pearls out there? Many questions on many exams. What are those little white things up the roof of the mouth? They're called Epstein pearls. They're just little retention cysts. They go away. They're insignificant. They just drive mom's crazy when she cries and she looks there and sees that. Sometimes you'll see similar little pearls on her gum line, alveolar ridge. And those are the same type of thing, the retention cysts. The problem with those is the kid gets 4 or 5 months of age before they get teeth and they're chewing on hard rubber things. Sometimes the edge of them will hit one of those and they'll rupture a little blood vessel and it'll bleed into it. So all of a sudden a little white pearl becomes a blue pearl. And that really panics parents. And then later on, if they chomp down on it and it bleeds, they get a real panic. So if you see it, it's best to tell them about it. When you find these little anomalies that don't amount to anything, if you tell the parent, yeah, you'll worry her temporarily and you'll have to spend a few more seconds reassuring her, it'll save somebody phone calls later. Brush. I could not find a good picture of a kid with thrush. We all see the coated tongues. If you can't scrape it off, it's probably thrush. On young infants, look around the neck. Because they drool. If they got thrush in their mouth, they're going to get thrush in the bottom of the neck. Some of them are going to get diaper dermatitis. Every great-grandmother, most grandmothers are not like this anymore, but every great-grandmother blamed it on dirty nipples. And then started out an exam in the office. I'd say, that's thrush. I'd say, I told you so. You take care of that young and got those bottles off the floor. You wouldn't have that. So I got smart one day and I blamed it on the grandmother. She looked at me like, what do you mean? I said, well, you get this book coming down the birth canal. So where did mom get it? She came in your birth canal. And it worked, so I started using that routinely. So I just tell mom, use me as the foil to get grandma off your back. I never lost sleep because of grandmother got mad at me. I didn't lose a lot of sleep because mother got mad at me if I thought I was on the side of being right. Geographic tongue over here. Other than Fritos and certain spicy foods tasting weird when you get that as an adult or as a teenager, it's just a conversation piece. Somebody will tell grandma or mom somewhere to tell about it, we have to reassure her. Canker sores. Most of them have canker sores. And one thing I would warn you about kids, don't use any of the numbs at medicine on a canker sore in a child. Because they'll sit there and chew on that place just like you do when you go to the dentist and they'll turn a little bitty sore into a huge gaping ulcer. And it hurts like the dickens. And my wife's vasolycine works for it. She's tried everything else over the last 40 years, so I'm not for sure I can believe her on that one. The one I do want you to look at is leukoplakia, the white patch on the side of the cheek. Every couple of years in doing a sports exam on a young man, I diagnose leukoplakia due to them doing dip. It's a precancerous lesion that needs to be removed. My favorite story, I was doing sports physicals on a school that sometimes got overlooked by everybody else in the county. And I found some kid that I thought football coach was going to kill the kid on the spot. Because he'd been preaching to him for 2 years not to use dip, and the kid was still doing it. But that's an immediate referral to the dentist. Or oral surgeon if you have one available. The nose, other than when you stick the foreign body up the nose, it's not very interesting. Normal carbonates, those are the ones that cool and moisturize the air we breathe. Little swelling in the lower one, inferior, or swelling, incomplete obstruction. The one rule of thumb I would tell you, if you get unilateral nasal discharge and it smells, it's a foreign body. I've had kids to stick everything from holly berries, peanuts up their nose. I had a physician wants to bring his 4-year-old in who had up to see an allergist in Louisville in a big fancy workup because he had this chronic drippy nose. He just happened to mention it was only one side. So we looked in the nose and he had a piece of one of those foam rubber sponges that was from chalkboards erased, stuffed up in there. And I just looked at it and said, you put your kid through all that allergy testing for this. I was a little disappointed in the quality of the exam that was done by the specialist too. That was an easy pickup because this has been going on for like 3 months. The neck exam, just looking at lymph nodes. Submental, submandibular, interauricular, anterior triangle, posterior triangle. If you get one here, most likely you got a tooth abscess in the front. If you look in there, you'll see a gum wall. Every gum wall is an abscess tooth. It's just a fancy name for it. Submental, I'm going to get that mixed up with the parotid. But look for, when you see these through here, look for lesions in the mouth. Most of them are viral. Canker sores will sometimes, especially in the front, will give you some swelling of the glands. If they're really not tender, I don't get too excited about them. The ones I do get excited about are the ones down in the inferior portion of the posterior triangle. That's too close to the areas that are associated with lymphomas. So if you find one there, if I find gland swollen through here, kid's got a viral infection, I'm not too excited. This one I'll have back followed up, or I'll be doing later, depending upon how long it's been there and how noticeable it is. If I'm the one that notices it and mom didn't, I may follow it. If she notices it and that's pretty obvious to me, then we probably make the next referral. Lymph nodes in the neck, front of the neck, most moms don't appreciate that they're normal. And it's a reaction to some type of infection. Probably the angriest my wife has ever been at me, other than when my son broke his arm and I didn't call her and tell her, was that we were on vacation. He got out of the pool and she noticed this knot on the side of his neck. And my son, being, really smart, healthy 5-year-old, like, Mom, Dad and I've known it's been there for a year. She unloaded on me when I got home from my meeting that day. But most of them were no problem. I really intended to come here and give you all fancy heart sounds and lung sounds. And then when I started preparing it, I was at a conference where they were giving a lecture on trying to get an audio-visual presentation. It reminded me how few times I've seen these types of things with photos, videos, and sound recordings go off well with a lecture. So I decided to do it. This website, Easy Auscultation, is the best that I have found. I actually checked with my cardiologist and pulmonologist separately. They both recommended it also. No normal, no normal. If you don't know normal, you can't play with sick. You can't recognize sick. So go thump, 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 thump. If there's something else except thump, thump, call a cardiologist. When I was in the residency, we used to take beds with each other. What if the murmur was, and the cardiologist, Dr. Newman, leaving to come by. With about 3 seconds, I would should diagnose it. And a month later, they do a cath and should be right on the spot. Now they do an echo and give you the results in about 30 seconds. So instead of worrying everybody, if it ain't thump, 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 get it seen. Lung sounds, probably only 2 lung sounds out of 3. And you know what pneumonia is, but then usually you got a sick kid, and it's really pretty obvious that will crackly sounds to hear. But wheezing and stridor. Stridor is associated with croup or foreign body and is an inspiratory type of sound. Wheezing is an expiratory sound, and I can't mimic that sound. Croup, inspiratory stridor occurs at 10 o'clock, 2 o'clock in the morning. Wakes everybody up in the house, vibrates the whole house. And it used to take me a while to convince parents that the louder they were, the better off they were, than that they were passing more air. When cell phones got to be popular, we'd get people who rush to the ER to get to the parking lot. Of course, the kid had been outside in the cool air, sometimes raining. The stridor had gone away, and they called, do we need to go in? I said, didn't tell you to go in the first time. So you can treat it, croup does get better when you go outside in the rain, in the cool fall air. But I would look at this site, that's one, easyauscultation.com. They have all sorts of minutes. Probably the ones that you're going to think about murmurs, VSD, PDA, and then Steele's murmur and the innocent murmur, which is a vibration. That's the one that gets picked up on sports exams on the skinny 11 or 12-year-old who's never been told they ever murmur before. And you can feel it vibrating the stethoscope as you listen. Excuse me. Lift the chest to the back. The straighten the child down. Obviously, the young ladies, you believe in a bra. Looking at the shoulder height, the shape of the chest. Look from the back. Look at the shoulders. Look at the movement of the spine. See where the scapula are. Take the sphenomenon, notice the peeking out. Rarely is that as significant a deformity as they grow up, the chest expands and intensity is minimal. Take the sex of the body, this the deep chest looks horrible in the deep croup. You just imagine how it caves in and anxiety level goes straight up. Sometimes the doctor's anxiety level goes straight up too. But most of the time, these will modify as the child gets older. Sometimes, if this is causing cardiovascular compromise, they have procedures to elevate that part of the chest wall. Not done very often, not done lightly. It's not easy surgery for a patient or surgeon. You all see the little bone right there? The xiphoid process. Probably on chest exam, I got asked more questions about that little bump there than almost any other thing. And it's just the lower part is the breastplate, the lubrium in the xiphoid process. In some kids, it sticks out some, a little not. And especially if a young infant where the chest is very flexible anyway, they take a deep breath in, it just sticks out more. And everybody knows there's something bad coming out. Reassurance usually takes care of that problem. I have had an occasional opportunity to have to refer to a pulmonologist to convince mom that that was normal. Breast development. Probably the 10 to 11 and a half year old skinny male gets more problems with early breast bud development. Breast buds get stimulated potentially by testosterone. So trying to convince an 11-year-old who's starting to enter puberty he's got a breast bud is a little hard to do. It's almost always asymmetrical, one side more than the other, occasionally both. It goes away 99.99% of the time. About 0.001% of the time you have to have that breast bud removed. In 30 years, I remember having to have it done twice. Scoliosis, obviously normal child here. You can look, we're a little off kilter here. The Adams test, looking for scoliosis, normal. This is where a lot of you put your scoliometer, which I have to admit I never used. They either had it or they didn't have it. And if I had a question, they would want to get x-ray to see what the angle was. This little girl's obvious. Any of you go to the beach this summer, I'll bet you walking down the beach, you'll see at least one case of scoliosis. And I bet you most of the time the person will know they have it, unless they've already started out with back pain. Very common to have some asymmetry. Matter of fact, when my young athletes would come in complaining of back pain, or the gymnasts would come in complaining of back pain, invariably they had a small degree of scoliosis, so it's already getting some asymmetry of the muscle strength. Small degrees are observed if the child already has a significant degree of curve. That's not good, and they need to be followed by an orthopedic surgeon who does back surgery. It's not an orthopedic surgeon that just puts scafs on arms and legs. They just made me some enemies in the orthopedic world, but I've told them to their face that they don't do it all the time. They're not seeing my kids with scoliosis. Having had probably a dozen kids or more over the years to have surgery, I always wondered if doing the body cast and all that would work better. And that message is still out on that. They have some orthopedists swear by them, others hate them. Some will swear that they fix everything, including chocolate cake. Others, well, just ignore them completely. And I'll be honest, I don't know for sure. Abdominal exam, 4 quadrants. You got the liver, you got the spleen, you got the appendicitis, and you got constipation. So if you feel masses in all those areas, you got different issues to deal with. There are a couple of tricks to examining the abdomen. One is putting your hand on the young infant's chest to help stabilize it in one place, and using the other hand to examine it real well. The older kid who's real ticklish and won't go jumping all over the place every time you touch a hand to it. If you will take that child's hand and put your hand on top of it with your fingers overlapping and examine with your fingers, you can do a good exam. For some reason, they're not ticklish when that happens. If you just try to tell them to be still, don't worry about it, it's not going to hurt. It ain't going to hurt. Umbilical hernias. Trying to say something good about umbilical hernias. Another thing that drives moms crazy. They want all the vaccines. You can see this one is a little pouched out. Most often printed like this. And once the cord falls off and heals, I'll actually try to have mom put her finger in the little hole so she can feel the rim of it to understand that it's going small, it's going to heal up on its own. And we'll watch it. I was usually very successful in getting moms with little boys with umbilical hernias to wait until 15 to 18 months or so to start getting smaller before they believe me. By about 12 to 15 months, mothers of little girls who had Audis were already going off the top of the ceiling. They did not like that. And occasionally we'd keep putting them off and putting them off. Then we finally sent them to one of the pediatric surgeons who would say, no, it's going to heal itself. So it was, then we got to say, we told you so. This one ain't healed itself. It may get smaller, it may get bigger. This is one that if they have to have a inguinal hernia, we're going to have some other type of surgery. We'll probably make arrangements for the pediatric surgeon to repair the umbilical hernia at the same time. Otherwise, sometime in the first 9 to 12 months, that'll probably have to be closed. How much of a problem are umbilical hernias? I can honestly say in all my years of practice, I probably only saw a half a dozen that gave me problems. Now, I probably saw several thousand who drove me crazy because it was driving vomiting, anxiety levels up the wall. It isn't pretty. You have to show them how to reduce it down. Show them, make them feel a little ring around there so they know what they're feeling when they get all the way back. And once they start to feel in control, they start to be much better. Rectus diastasis. That's the hernia that turns from the xiphoid process down to the umbilicus. The two big rectus abdominis muscles. Maybe the tissue that connects them is weak. When the kid starts to lean forward and contracts them abdominal muscles that bulge out. Usually gets better with age, though it's not uncommon to have adults, senior adults, to have this have to be repaired. How would you find these foreskin adhesions? There's debate how to treat these. My personal way was if they were very thin, to manually lye some, get it all over with in about 3 seconds. And one put Vaseline on it and show what to do in the future. If they're any tighter than that, we usually will have the pediatric urologist take a look at it and make a decision. And they usually took 3 seconds to lice it. But it wasn't, the kid wasn't screaming on my couch, it was screaming on somebody else's couch. In females, the labial adhesions, the labia minora, with puberty, those will open up on its own. However, the problem is that that area there that's closed off, that's where the urethral os is. And it starts to cause the urine to recycle. And we start to at least increase incidence of UTIs. So if you have a little girl in the first 2 years of life that's getting recurrent UTIs, do a GU exam, and I bet you more than half the time you'll see they have labial adhesions. How you treat those? Some people use steroids, some people use Vaseline, some people will give them fixtures primarily. And it doesn't cause any changes other than the external lining of the labia, and it's not permanent. Hydrocele, one side of the scrotum, or sometimes both sides are markedly swollen. You can light these with a slide. You see the increased flow. That's all the water. If it's if it's a tumor of the testicle or hematoma of the testicle, you don't see the light reflection on that. Oops. Carmel skin tightening on little girls. I have to admit, the first time I saw one of those, I panicked because I had not seen one in residency. I had to have my adult OB/GYN guy in private practice come over and look at it. He educated me, and not such a nice, pleasant voice, typical surgeon. But he was good. I used to tell parents that when I was referring to a specialist, I was not referring because of the personality I was resenting or reading their knowledge and their technical skills. So there's a difference when it comes to some of you have already found out, I suspect. Notice in the testicle, there's 2 types. Those that are retractile, and you can go back down into the scrotum, in which case the scrotum is usually symmetrical. And those that the scrotum is asymmetrical, and that testicle ain't going no place. When I was first out in practice, this point, it was 15 to 18 months referral. Now it's sometime between 7 and 9 months to get to the pediatric urologist. But if you can milk that testicle down into the scrotum, and the scrotum is symmetrical, it's still got a good chance of going down on its own. They probably won't do anything until the kid gets a little older, if they have to. Just a quick collection of orthopedic findings, which I'm quite sure all of you have been asked me these things. The syndactyly, where the toes or fingers are fused together. I'll be honest, in private practice, I only saw one kid with syndactyly fingers. It was only partial. But it seemed like every month or 2, I had a kid in the office who had syndactyly toes. And a mom once who came in really angry. She was like 4 months old. She found a web in one of the kids' toes, but I had not found in 4 months. And I listened to her, put the blame in the appropriate place, and I asked her, I said, how many times a week do you bathe your child? She said, well, every day. I said, so you bathe your child every day for 4 months, and you just picked this up last night? I've seen your kids 3 times. And no, I don't count. I count the toes, but I don't look between the toes. The other thing I would do is I'd have, especially if it was in the spring or early summer, with all the family reunions, I'd ask moms, nobody ever had a family history. Nobody in the office ever had a family history when I asked them. So I'd say, okay, when we go to the family history, like a reunion this summer, have grandma to go around and ask all the people about their toes. And invariably they come back in the fall sometime and say they found 2 or 3 or 4. One family found 6 kids. And some guy that was like 95 and he didn't even know he had it until he looked at his toe. So it's relatively common, but it's humorous. I do not know the genetics of it. I assume there is some. Polydactyly, an accessory toe for the finger. I really never saw this in private practice. The thumb I had an engineering professor who had a split thumb. He used to put this chalk in there and walk around the room. Now, listen, how many of you think we were following what he was putting on the board he was talking about? He was sitting there raised with his thumb. Developmental dysplasia of the hip, congenital hip dysplasia, most of you don't have. Two tests, and you ought to do this on every well child visit up to at least 6 months of age. Some of those kids will be late bloomers. I had one child who, all 3 of my partners, including me, that examined this kid, that did not show up until he was like 8 months old when he started to walk. Turned out good, but it was a little scary. If you can remember the difference between the Barlow and ortholonic test, you ought to pass this course with no problems. I just know where to put my hands, in and out, push in and out. And if it's subluxed or dislocated, or you don't get a little click, you get a clump. And there's no question about it. It causes the potential for medical legal problems. If you feel it, you probably ought to get an orthopedic consult. Whether they decide to double diaper or put in a pelvic harness, let them make that decision. If some babies are breech, all babies are breech, I'll recommend to have a ultrasound or hip ultrasounds. Sometimes the 2 form of range to check on it because they have a decreased chance. Bowing, non-bead, and pigeon toe. I mean, I'm going to get questions about that on a regular basis. The typical questions first come up with Bowie when the kid is trying to stand up and cruise around. And put a big bulky diaper on a kid who's got Bowie and it just looks horrible. We used to have a picture in the office that showed moms that Bowie was very common when kids first started walking. At 3, they were not knee, but 6, they were straight. Occasionally, I would have a mom who would insist upon an orthopedic referral. And he'd show them the same darn picture. So, if grandma had been the one who instigated the referral, I'd tell mom to have her to pay the copay. But very, very common. This 3 to 4-year-old with a non-knee is the ones who the little girls come in with bruises on the inner parts of their knees. Rarely do any of these problems cause any significant problems unless Bowie persists, or if it's really pronounced or at least there's condition on Wallace disease that is very pigeon toeing, in toeing, and overpronation, which is sort of flat feet, are relatively common questions that are asked. The overpronation is probably the most common foot problem, leading flat feet. The ones obviously are blessed with oversupination have a harder time finding shoes. But the way you can tell if it's really affecting the child, look at the bottom of their sneakers. If the inner part of the sneaker is worn, they're probably having significant weight-bearing issues with overpronation. That's when orthotics may help. This is in the child who's 5, 10, or 12. That's on the outside, and that's when orthotics may help for oversupination. End toeing is an interesting pigeon toeing because there's 3 places it can occur: the hip, the foot, or the leg. Carmel inversion is the femur has a normal twist to it, a little bit of a twist. It turns the whole leg up. Internal tibial torsion, the tibia rotates inward, but the femur, the spine, and then the foot. The way you tell the difference in these two, you put your fingers on the epicondyle, called the femur, and put your fingers on the lateral medial malleus. And if they're in the same plane, it's probably the foot. It's not the femoral inversion or the internal tibial tuberosity. If they're asymmetrical, it's usually internal tibial torsion. The reason why it's important, some of these will respond to certain types of bracing and appliances. Most orthopedists don't get into that because they understand it's going to get better on its own most of the time. I had a grandmother once who was insisting that I make a refer to an orthopedist. And finally I asked her, I said, which type do you want me to send them to? She was a little taken back. And she said, well, pediatric orthopedist. I said, no, that wasn't the question. You want me to send them to someone who's going to treat you or someone who's not going to treat you? Because this is going to get better on its own. She said, well, we'll watch it. Flat feet are normal until 2 years of age. There's a fat pad there. Gradually it's better. 20 or so have arches. Metatarsus adductus. The forefoot is turned in. The ankle is aligned correctly. There are different ways of treating that. Usually the easiest way is to put your thumb and forefinger in one hand here. And put your finger, or your thumb and index finger on both sides of this foot. And just mechanically straighten it out. Have mom to do that about 15 repetitions, 4 or 5 times a day. I find that it really seems to be more fixed. That's when special last shoes will help. But some kids are not ready for shoes at certain ages, so why torture them up? Then the traditional club foot. It's positional, it doesn't, or non-positional, it doesn't correct easily. That child goes into serial casting. And most of them turn out really well. Neural exam, Best way to do a neural exam, depending on the age of the child, is put a quarter on the floor and ask him to pick it up. That child can bend over and get the quarter, or sit down on the floor and get the quarter and stand back up. And you notice there's no undue balance problems or issues, not climbing up on his legs. Probably on a normal neurological exam. Of course, it has to be age appropriate. The moral reflex is the one where you lift the child's back, shoulders off the bassinet and then let go when you get this crying, screaming. That's important if it's asymmetrical. It doesn't matter how much they scream, how much they holler. The examiner, this is part of the observation. The child's climbing, interacting with the examiner, playing, walking, jumping, and looking like the Super Bowl bouncing from wall to wall. Probably normal neurological exam. Some more primitive reflexes, the tonic neck reflex. Turn the head one way, arm sticks out, and the leg straightens on the inside. Grasp reflex, step reflex, and the crawl reflex with their, what I call their turtle pose. Nerve palsy. One reason to do a normal reflex on a kid in the nursery or 2-week-old is if they don't move one arm well. That could be Erb's palsy, which is a brachial plexus injury. It can also be a fractured clavicle that they get picked up in the nursery. And a good number of those improve with time. Romberg test, probably on the older kid, nice and good, easy test to do that tells you a lot. Have to stand up straight, arms down to their sides, close their eyes. And if they can stand there for 5 seconds, they probably have no one to watch, would say. Reflexes, good luck. Those are, that's not appropriate to talk about those. Basic reflexes, remember, infants' toes go up, adults' toes go down. When adults' toes go up, or older kids, adolescent, that's on normal. Any questions? Yes.
The question I've been asked a lot is tippy-toeing,
Yeah.
kids walking. When, is there a certain time, or does it have to do with shoes, no shoes? When do you refer?
Yes. One, if I see the child standing down on both feet, I get less concerned about it. Two, I check for the heel cords if they're too tight. If I can bend the forefoot back on the ankle more than 90 degrees, then I don't tend to get very concerned about it. If I can't get the foot past the ankle, it's like a 90-degree angle, which would indicate tight heel cords, then I'll usually have a physical therapist to work with. But rarely does tiptoes cause a problem. Yeah, and I'll tell you another
You
thing.
get that, you get that.
Oh, yeah. I just say, just think how different balance is if they do it on their tiptoes. The other thing, if you've got someone who's worried about a little bit of in-toeing, pigeon-toeing as the child gets older, if you don't notice any asymmetry in the wear of the shoes, easiest way to calm them down is tell them have to watch the Major League Baseball. Watch the runners who are really fast on the bases as far as stealing base. They're all a little bowed and a little pigeon-toed. It's a well-documented fact, I'm not making it up. But you're a little faster if you're a little pigeon-toed or bowed. That usually took away all dad's concerns. As a little girl, there were still some concerns about high heels and progresses and all that. So didn't have much I could go for that. I'm going to track. Any other questions? Thank you.